Good evening, everyone. Welcome to API DIAS. And as all of you know, API is the body of physicians, and world over, it is known for its academics, knowledge, and the culture of association in medical field, encouraging each and everyone to learn and to deliver their best. And so far as the API DIAS is concerned, for almost a decade, it is delivering knowledge to the physicians, not only in India, world over. That is, a DIAS stands for dissemination of information through API physicians, and the same information goes to each corner through the doctors who are members of API and also working day and night with a rich clinical experience. So again, during the COVID time, we have come digitally, and the theme digitally is the outreach, digital outreach during this crisis, and we have one after another important issues to reach each of our member. And as you know, today we have a session on thyroid with DIAS on the field. For a formal inauguration, I invite all of you to today evening session. And to start with, I welcome Dr. Arul Raj, our president of API. And Dr. Raj is not only a very good academician, he was a very good student in their earlier time. He has been an intensivist, a successful critical care physician, a non-invasive cardiologist, and worked in a very broad base of medicine, starting from the internal medicine, cardiology to the critical care medicine. And now he is the head of the Association of Physicians of India. And in his stewardship during this difficult time, we are having digital programs. And I welcome Dr. Arul Raj to today's CME.
Thank you, Dr. Panda, for the nice words said about me. Good evening to all of you. Our respectful chief guest, Professor Srinath Reddy, and our Dean, ICP, Dr. Sashank Joshi, the pillar of API, our Secretary General, Dr. Mangesh, and learned faculties, Prasun Dev and Dr. Ganesh, and this Abbott team. Very warm welcome to all of you. Already, anchor has explained to you, what is API DIAS. I would like to stress that today it is an era of digital India. Our Honorable Prime Minister is for digital India. Therefore, in healthcare also now digitalization is the order of the day. Digitalization in learning and delivering healthcare, and even our examinations and assessment, everything is going to be, digital. Therefore, we are encouraging a digital, CMEs in the form of an API DIAS. I'm extremely thankful to, Abbott Group and our API team for reaching to thousands of physicians of this great nation. I'm sure the number will keep going. Now coming to today's program, it's an excellent program. I must thank our API team for the choice and the faculties. When I was a student, undergraduate students in 1960s, I've been taught, you learn syphilis, you learn medicine. In 1980, when I was in my peak of my practice, my mentor, Professor Sanjeev Moses, said, you learn diabetes, you learn medicine. And this he made a statement in ADA also. And in 2020, you learn thyroid, you learn medicine. To that extent, thyroid has become a systemic disease. We have chosen the topics on thyroid dysfunction, whether it is a hypothyroid or low T3 syndrome or subclinical hypothyroidism, what effects it has on the cardiovascular system, on the vascular system internally, on the endothelium, what happens, and what happens in the muscles, what happens in the conduction system. Lot of studies are on. And API, after trying to specialize into cardio-diabetes medicine, Now my direction has been towards a thyrocardiovascular disease. We have had already 2 symposia on that, and actually API is preparing a monogram on thyrocardiovascular disease. I am sure the valuable inputs of the faculties of today's meet will also find a place with their consent in that, and that will be an excellent, monogram for the practicing clinicians. Because now today you will have to, whichever, medical problem you treat a patient, a hypertension or a coronary artery disease or a cardiac failure or a renal failure or even a pulmonary, why not? Even a pregnant lady, a thyroid estimation is very, very, very important. And a lot of subdivisions have come. We have been taught by primary hypothyroidism, secondary hypothyroidism. Now, clinical hypothyroidism, and then a overt or an, critical hypothyroidism, low T3 syndrome, and then a subclinical. Lot of subdivisions have come. I'm sure people like Dr. Shashank will be able to make us understand on these, intricacies and take it forward to our clinical practice. With this, I am happy to inaugurate this APA DIAS session on thyroid dysfunctions and cardiovascular diseases. Thank you, for one and all. Thank you so much.
Thank you, sir, for those nice words. And under your stewardship, even during this difficult time, we are moving digitally, and this is digital outreach for acquiring knowledge in the API Dash. So I welcome all of you again on behalf of API, the knowledge body of India, and then we'll go to our dynamic honorary secretary of API, Dr. Mangesh Tiwashkar. He was a brilliant student with gold medal in his undergraduate career, and he has been involved in the editing work, in the organization work, as well as a researcher, a academician, a presenter in many conferences. And we are fortunate to get him as dynamic secretary of Association of Physicians of India. And during this time also, he's managing the organization very well. So we welcome Dr. Mangesh Tiwashkar, our dynamic secretary. So now we'll be listening to Dr. Shashank. Our honorable Dean ICP, Professor Shashank Joshi, is not only a Padma Shri, he's an endocrinologist attached to Lilavati Hospital and Apollo Sugar, as well as the Vatia Hospital. He is a state-of-the-art, best clinically a very efficient endocrinologist whom the whole world has recognized, and we are proud that he is today he will be presenting a important topic in this program. And at present he is the secretary of Indian Thyroid Society, and he is the past president of Association of Physicians of India, as well as the Research Society for Study of Diabetes in India. And because he is not here, we'll be listening to his message, and I request the team to play his message.
You see, it gives me a great pleasure that the academic wing of API is the Indian College of Physicians, and Dr. Arul Raj has taken and continued this API DIAS program, which used to be a physical program, which used to go to almost 80, 90 cities, towns, and parts of India to do skill building. He has converted this whole knowledge dissemination exercise into a digital platform. The two main thirst areas which I want to talk is, one is the telehealth and telemedicine, which he very nicely said that today is the era to adapt and learn skills. We need to use technology right up to artificial intelligence in its best way. And second key is the patient to physician communication also is going to use the same telemedium. And therefore today the key is, the word is the tele. But at the same time, we should not get digitally intoxicated. And I always say in all my programs that you should do a 2 hour digital detox every day. At the onset, I really congratulate Dr. Arul Raj for wonderfully crafting this program. And my very close brother, Dr. Mangesh Tivaskar, very astute Secretary General of Association of Physicians of India, with the help of our team Abbott. Let me tell you something about Team Abbott. They have virtually had no influence on this program. This is a completely unrestricted grant from them, and they have allowed us to take topics which are useful for the practicing physician and the clinicians, so that they can not only learn, but whatever they learn, they can adapt it into their day-to-day practices. And that is so critical and vital in today's times. Also, what is useful is that we need to recognize that healthcare is soon going to get digital, and it is going to become a interactive digital platform, and which is what we are using today. And that is something which is very, very pertinent in the today's era. We also would like to make an effort to capture your feedback and translate it. But the whole aim, as Dr. Arul Raj very nicely said, is that we need to ensure that what you listen, you learn, what you learn, you adapt. And I hope that the various pearls of wisdom in different domains of medicine, which will be spanned over this year, you will learn digitally. And actually, this outreach, which Dr. Arul Raj said, is actually going to reach out to many more people. I was the second president to continue this API DIAS program, but we could reach a finite number. But now with digital health, we can not only reach within India but outside India. And I would request everyone to make this program into a larger domain so that more and more people can listen, learn, and adapt.
Thank you, Professor Shashank, for those nice words. As you know, the DIAS started way back in 2013 during the period of Dr. Muruganathan, and then Shashank and Dr. Bansal and others, Dr. Banshode and others, they took over till we are doing it digitally. And for last 10 years, this is continuously working, disseminating the knowledge throughout the different cities and the remote areas of the country. So with this, I thank our Honorable Dean ICP for his nice words, and we'll go for ahead with our chief guest of the evening. And we have someone who is very inspiring in his career and his presence in today evening's program. Professor K. Srinath Reddy is not only a Padma Bhushan awardee, but he is the formerly head of All India Institute of Medical Science, and he is at present the president of Public Health Foundation of India. And he has started almost five Indian Institute of Public Health during his tenure, and his services and his expertise is not only limited to the country only. He is the first Bernard Blonde visiting professor of health at the Harvard School of uh, uh, Public School, and also at the Rollins School, and also at the Sydney. He has contributed as a visiting professor, and he's the first Indian to be elected to the National Academy of Medicine in the USA, and he is an advisor to many governments, including Odisha, Punjab, Haryana, Andhra Pradesh, and others. So today, such a think tank, such a person knowledge source, Professor K. Srinath Reddy, the president of PHFI, is with us. I invite Professor Reddy for few words in this inaugural session.
Dr. Arul Raj, Dr. Joshi, Dr. Joseph, Dr. Panda, and distinguished colleagues in the faculty of today's session, as well as the delegates who are participating in this very important CME sessions. Good evening to all of you. I believe the importance of CME, or dissemination of knowledge, so that knowledge can be quickly translated into practice for the benefit of the patients and humanity at large, need not be really stressed. That is the very purpose for which this event has been organized and for which you have registered. Nevertheless, it may be useful to recall what Charles Mayo, the founder of Mayo Clinic, said are the objects of medical education. He said those objects are to heal the sick and to advance science. Of course, he did not talk so much about prevention, which is also important, and that's where public health too comes in. But even when we look at healing the sick, it is absolutely important for us not only to understand what science is telling us at a particular point in time, but also keep abreast later on of all the scientific advances which are unraveling many of the mysteries when we are practicing, which we encounter, and also apply the learnings from emerging science to the best advantage of the people whom we are trying to heal. And that is where interpreting knowledge, which is accumulating so rapidly in terms of scientific advancement, becomes absolutely important. And indeed, the profusion of scientific journals and the articles in them are so huge that we do require experts with adequate insights into that scientific literature to interpret them for us and to engage in a discussion which is going to be fruitful in terms of how best we can apply the fruits of that scientific knowledge into our own practice, ultimately for the benefit of the patient and the wider humanity. But we recognize that in the scientific method itself, there are two issues. One is internal validity and external validity of the evidence that is communicated in these scientific journals or the research articles that are published. Internal validity, of course, depends upon how best we can identify truth as opposed to the influence of chance, bias, or confounding. How we can extract what is the best approximation of truth. But then we also need to see how generalizable it is and applicable in our context, which is what we call external validity. And that is where national experts become absolutely important in order to try and interpret how best that scientific knowledge which is published in international journals can be accommodated in terms of our own practice. And of course, as Indian science advances and Indian research too becomes extraordinarily productive, then we have our own contributions which we can also understand after adequate discussion with the experts. Therefore, in order to ensure that our day-to-day practice, whether it is diagnosis in term or treatment or rehabilitation or palliative care, whatever is the continuum in whatever it is in the continuum of clinical care that we are dealing with, it is absolutely important for us to assess the evidence and try and distill what is the truth from that and how relevant that is for our clinical practice. And therefore, these kind of sessions are absolutely important, and we share experience and expertise with each other. Everyone teaches and everyone learns. Of course, you have some very experienced faculty to guide the discussion, but even the delegates who are attending have plenty of experience to share, and it is that discussion that becomes very enriching. And I'm happy that this is actually happening through these sessions. And non-communicable diseases have emerged as extraordinarily important in India, both in contribution to mortality as well as disability. But we have often fragmented our examination of those as cardiovascular disease or endocrine disease or gastrointestinal disease or neurological disease. What we must recognize is the connectivity within the body and the mutually interdependent function of various homeostatic systems. And even when disease strikes, we find that interdependency of various organ systems. And therefore, looking at thyrocardiovascular disease as the theme is absolutely appropriate because we must understand these connections when we are looking at how best we can treat our patients. And certainly as a cardiologist, I would say anything to do with thyrocardiovascular disease is close to my heart. And I'm happy that's the theme of these sessions. I wish you the very best of learning, but we must also recognize, as has been already stated, both by Dr. Arul Raj and by Dr. Shashank Joshi, that we are living in a period not only of amazingly accelerating science, but also of several technologies which are available to us in the application, whether it is diagnosis or treatment. And we are seeing, of course, technology coming to our aid in this particular session where we are able to communicate to a large number of people. But we must also recognize how best to interpret the use of technology in the context of a particular patient, whether it's a diagnostic test or when to apply a technology for a treatment. And therefore, while technology is an enabler, it is not a substitute for sound scientific judgment. Even to understand where technology is appropriate and which context it is best used, we require a certain understanding of science, and we require the support of experts to guide us on that path. And therefore, these kind of exchanges are remarkably useful in bringing the best of science as well as the strength of technology into our patient care. And I wish all of you a very enriching learning experience. And I thank you again for this opportunity to be part of this gathering this evening. And I hope that this particular session will be very useful in advancing clinical care across all of India. And I understand there are also international participants who are also part of this session. And I hope the global outreach of this exercise will also benefit patients in other countries too. Thank you very much.
Thank you, sir, for those words of wisdom. And as all of you know, the presence of Dr. Reddy itself is inspiring for all who has gained the international recognition of his service and his expertise, and in his leadership, the PHFI has achieved a high place and arranged academics and training of many youngsters in the country. Thank you for those nice words. And with this, we'll move on to our director, managing director of the Abbott India Limited, Mr. Anil Joseph. And this initiative, the API DIAS initiative, is a partnership with Abbott. It's a API partnership with Abbott. And from the beginning, they have allowed an unrestricted grant, as Dr. Shashank has already mentioned, for the dissemination of knowledge, information by API speakers. And this is continuing almost for a decade without any hassle, without any break, and disseminating knowledge to every corner of the country and the world. And the managing director of Abbott India Limited, Mr. Anil Joseph, is with us, and he is a master in business administration from prestigious Symbiosis Institute of Pune, which has given the business management degree, and he has worked in the best of the firms of the world, like Coca-Cola, like Johnson, and he was the head of transfusion medicine of Abbott, and at present he is heading the Abbott India Limited and also Abbott established pharmaceutical division as managing director. And Abbott, in its effort, has continued this academic program throughout. And I invite Mr. Joseph to please put few words in this occasion of API DIAS on thyroid diseases. Mr. Anil Joseph.
Thank you very much. It's a great pleasure to be part of this program. Respected Dr. Arul Raj, Chief Guest Dr. Srinath Reddy, respected Dr. Panda, Dr. Shashank Joshi, Dr. Mangesh, and respected members of API. It's been a great association that we've had with API and creating platforms to disseminate knowledge is something which we have used all opportunities to do, because we know that that's ultimately what leads to emerging with the best healthcare that is so required in our country. If you move to a next slide, Abbott is a global healthcare leader that helps people to live life to the fullest at all stages of life. We have more than 100,000 employees of Abbott around the world and more than 10,000 in India. We've globally been in business for more than 130 years. And you'd be interested to know that Abbott is one of 52 companies from the original Fortune 500 and just 59 from the initial S&P 500 that remains on the list today. We serve people in more than 160 countries with a portfolio of life-changing technologies that span the spectrum of healthcare. We have leading businesses and products in medical devices, diagnostics, nutritionals, and branded generic medicines in emerging markets, generating sales in excess of $30 billion. In the next slide, our fundamental goal is to help people live fuller, healthier lives, maximizing their potential at all ages and stages of life. Our medical devices use advanced technologies to keep hearts and arteries healthy, to treat chronic pain and movement disorders, and to give people with diabetes better insights, more freedom, and less pain. Our nutrition products build and maintain your health from infancy onwards. Our diagnostics provide information to guide effective treatment decisions. And our branded generic medicines help people in emerging markets to become and stay healthy. The next slide, please. We have market-leading positions in every one of these businesses. Abbott is number one in remote heart failure monitoring, in stents, transcatheter mitral valve repair, in heart pumps, continuous glucose monitoring, in chronic pain devices, point-of-care testing, blood and plasma screening, adult nutrition, pediatric nutrition in the United States, and in medicines for pancreatic enzyme deficiency, progesterone hormone therapy, and vertigo. On the next slide, we're also a world leader in medical devices with a broad portfolio of advanced healthcare technologies. For years, our medical device businesses have offered technologies that are faster, more effective, and less invasive. Today, we are focusing on personal technologies that empower people with the data and knowledge they need to help them live longer and better. Our connected care and digital health tools, from mobile platforms to wireless implants to wearable sensors, are helping people and their doctors make better, faster, and better informed decisions about their health in ways that fit easily into their lives. The next slide, please. In diabetes care, Abbott's focus is on providing accurate results faster to more people and with greater convenience. So people who have to monitor their glucose levels can do so with minimal pain or disruption. We're the world leader in continuous glucose monitoring. Our next generation sensing technology, the Freestyle Libre system, is a life-changing innovation that offers elimination of routine finger sticks to draw blood, actionable insights and improved outcomes, a more affordable option compared with other continuous glucose monitors available today. Freestyle Libre users can get a glucose reading plus record the trends in their levels by just swiping an app-enabled smartphone over their Libre sensor, and is now available in nearly 50 countries and is reimbursed in more than 30. Next slide, please. We are committed to bringing the benefits of our trusted medicines to more people in the world's fastest growing countries. We offer a broad portfolio of high-quality branded generic medicines across multiple therapeutic areas: gastroenterology, women's health, cardiometabolic, pain management, and respiratory. This diverse portfolio includes the world's leading medicines for pancreatic enzyme deficiency, and as I mentioned, progesterone hormone therapy and vertigo. Next slide, please. Every day, more than 18 million people around the world use our medicines. In this business, we differentiate ourselves from pure generic competitors in many ways through our exacting quality standards, a reliable supply chain, superior clinical science, broad product range, and patient-centered innovation. We also offer services such as A-Care, the first of its kind digital platform that gives patients and healthcare providers tools, tips, and resources to better manage people's health. We offer market-specific portfolios that reflect the health needs of each region we serve, with special emphasis in core therapeutic areas where there is unmet medical need. Next slide, please. It's been 110 years of breakthrough health products in India. We now have 3 manufacturing plants in India bringing products into the market faster, and a dedicated innovation and development center supports our localized research requirements. In the next slide, just like to tell you about the ways that we've pioneered innovative ways to screen, diagnose, and monitor a vast range of health conditions with greater speed, accuracy, and efficiency. As a result, we've become a leading name in immunoassay diagnostics, in blood screening, bedside testing, and companion diagnostics, tests that provide information essential for the use of a corresponding medication or treatment. Abbott is a market leader in tests and instrument systems for hospitals, labs, blood banks, and clinics for general health screening, for disease diagnosis and monitoring. Our blood screening systems and tests are used to safeguard over 60% of the world's blood supply. Molecular instruments and tests to realize the promise of personalized medicine for managing infectious disease and serious illnesses. Patient-side blood testing for lab quality results in minutes. Sophisticated information solutions that efficiently share information across the health system, enabling fast and better informed decisions about treatment. And Abbott has also become a leader in testing in the fight against COVID-19, developing multiple tests to detect the virus and antibodies to the virus. The next slide. Abbott has been named by Fortune magazine as one of America's most admired companies every year since 1984, and ranked the #1 company in our industry for the past 7 years. This honor is a result of excellence across our company. We've been ranked as the industry group leader on the prestigious Dow Jones Sustainability Index for the 7th consecutive year. It's the 15th year in a row we've been named to the index. We were named to Fortune magazine's list of best big companies to work for in 2020. One of Diversity Incorporated's top 50 companies for diversity. One of the best places to work in more than 25 countries. Working Mother magazine has selected us as one of the top family-friendly places to work for. One of the top 20 best employers for scientists. And our innovative products have received numerous recognition through the years, including for our Freestyle Libre glucose monitoring system. And to the last slide. Abbott has been helping people live more fully for more than 130 years. We value our achievement and the perseverance it takes to accomplish challenging goals. This is reflected in our sponsorship of the Abbott World Marathon Majors, and it's evident in the way that we approach the important work that we do. We're proud of our long history of success, but we're constantly looking to the future, seeking new and better ways to help people live their best and fullest lives. We're strong, we're focused, and we're ready for the future. It's a pleasure to be part of this August gathering, and we hope everybody benefits from all the learnings that are going to be shared. Thank you very much.
Thank you, Mr. Anil Joseph. That was a very nice presentation about a world leader. And we thank you for your association with API. And API about initiative, the dissemination of information through API speakers is continuing for almost a decade in various fields of medicine, presenting the topics needed for our physician practicing and also youngsters studying. So with this, we'll move on to the scientific program. I thank our chairman, Sri Dr. Arul Raj sir. I thank Dr. Srinath Reddy sir. I thank Professor Shashank Joshi. I thank Dr. Mangesh Tiwashkar. I thank Mr. Anil Joseph and the whole team who have arranged today's symposium. And this is with this very brief inauguration, we'll move on to the scientific program part. And here I invite our president, Dr. Arul Raj, to chair the session. And we have three very interesting topics on subclinical hypothyroidism, on cardiovigilance in thyroid disorders, as well as in antithyroid drugs, how much and how long. So I request Dr. Arul Raj to chair over the session. And with this, I'll invite our first speaker, none other than our Dean, ICP, Professor Shashank Joshi, who is a leading endocrinologist of the world and attached to the prestigious Lilavati Hospital, Apollo Sugar, and Vatia Hospital. At present, he is the Secretary of Indian Thyroid Society and the past president of API and RSSDI. And Dr. Joshi has many publications to his credit, and you are seeing him dominating the Indian academic field almost for last 3 decades. And we present you Professor Shashank Joshi for the topic subclinical hypothyroidism, when to treat below 10. Professor Joshi.
So thank you, Dr. Jayant Panda and Dr. Arul Raj. At the onset, I thank all of you all for keeping thyroid, but I'm pretty disappointed with the Mr. Anil Joseph that he talked of every other disease, but thyroid was comfortably left out. So this is the step motherly treatment which thyroid gets, even in global presentations. He talked of nutrition, he touched on COVID, he touched on diagnosis, he touched on telehealth, he touched on everything on planet Earth, including heart disease and diagnostics and even nutrition. But you saw that thyroid was never mentioned. Hormones were mentioned, but thyroid was never mentioned. So this is the poor thyroid always gets a very step motherly treatment. And I'm at least happy that API decided to include thyroid here. Though Abbott happens to make some thyroid medicine, I think it is probably not in their profiteering range, and it must be under price control, which is why they don't leave in their major presentations. I wish that next time he doesn't forget to mention thyroid, because I think they are the global leaders in thyroid, but they don't like to be associated with that. Sometimes they should do that. So I'm pretty disappointed. I must express, because I'm a very frank and a transparent individual. So I must record my displeasure and disappointment. So let us look at the subject. Thyroid is exploding across planet Earth. And when you have a TSH about 10, it's a no-brainer that we need to give them some thyroxine. But if somebody is below 10, should you treat, should you not treat, is a big question. And that's what I am going to talk in the time space which has been given to me. So when you define subclinical hypothyroidism, what does it mean? It means that it's an elevated TSH where the T3, T4 or free T3, free T4 levels are normal, and there are hardly any signs or symptoms of thyroid disease. This is a digital outreach program for knowledge upgradation. So any TSH which is outside the reference range for that lab with a normal T3 or a normal free T3, free T4 without any signs or symptoms is subclinical hypothyroidism. In fact, globally, there has been a big, debate between clinical chemists and clinical biochemists. The International Federation of Clinical Chemists feel that the normal TSH should be about 2.5 or 3, and any TSH about 2.5 and 3 is abnormal. And the clinical biochemists and pathologists have argued that we should always maintain 95% confidence limit and anything which is outside the reference range of that lab for 95% confidence limit is an abnormal TSH. So when the chemist and the biochemist will keep on debating and they will try to lower the TSH norm, if we lower the TSH below 2.5 and 3, you will see probably half of planet Earth will become hypothyroid. Now remember, never dismiss thyroid. Even today, we might have 80 million diabetics, but there are probably 55 to 60 million thyroid patients in India today. So it's a very large population because we are at the peak of iodinization. And when you are at the peak of iodinization, remember, iodine behaves like an immunogen. And that's why we are at the peak of autoimmunity. And that autoimmunity is driving a thyroid disease. And a lot of that thyroid disease is subclinical, which means when you screen them in the biochemistry, you will find an abnormal TSH. And often that TSH is above 4, 4.5 based on the reference range of the lab up to 10. And that becomes a dilemma to treat or not to treat. But this is a definition of subclinical hypothyroidism. So as I told you, that patients with subclinical hypothyroidism are categorized into two: mildly elevated TSH between 4.5 and 10, and markedly elevated TSH above 10. And that's the simplistic way of doing it. So what is the data? What is the epidemiology of subclinical hypothyroidism in India? It varies anywhere from 1 in 4 Indians, that is as high as 26% by Rohil et al., to maybe around 6% by Sahu et al. So anywhere between 5% to 25% is the prevalence of different geographies. India is a huge continent, and you can see that it is rapidly, as the times are going up, probably close to 15% of India has an abnormal TSH. That would be the main thing. So when we talk of thyroid, usually what I allude to is primary hypothyroidism, where the thyroid gland is under stress. Of course, we have secondary where the pituitary is not functioning appropriately, where the TSH is often normal and the T3, T4 or free T3, free T4 is low. Or it could be tertiary, where the hypothalamic injury or hypothalamic disorder can cause it. Again, where the TRH, which will influence the TSH in the pituitary, will impact the T3, T4. So I'm not talking about the central hypothyroidism here at all. Remember, very rarely you will miss central hypothyroidism, where the TSH is normal, T3, T4 is low, and you should always do an ATM cortisol with that. Because often if you treat them with thyroid and don't treat them with a small dose of steroids, you will actually cause an adrenal crisis. So that's very critical. Having said that, the garden variety thyroid disorder which we get is primary hypothyroidism. And the first one which kicks up is the pituitary thyrotrop. The pituitary thyrotrop suddenly will increase the TSH quick and abruptly. And years before severe or moderate hypothyroidism ensues, you will see the TSH spiking up. While the T3, T4 production of the thyroid gland will go down very slow, and a little low. So remember, TSH goes up first, it goes up abruptly, while the T3, T4 declines a little later. So obviously, what causes this thyroid dysfunction? As I told you, we are living in an era of autoimmunity. We are into a digital era, as I said before. Everybody nowadays learns their thyroid from Dr. Google or Mr. WhatsApp. And the first thing my patient Google out is, do I have Hashimoto? So the first thing I tell them is Hashimoto is a ophthalmologist from Japan who's in his grave now, but he described this autoimmune thyroid dysfunction and it has been nicknamed as Hashimoto's thyroiditis. But to put it very simply, it is auto destruction by antibodies of the thyroid. Commonly, the antibodies which we do are the anti-TPO antibodies, the thyroid peroxidase antibodies, which are done. Now, individuals with subclinical hypothyroidism are asymptomatic. The manifestations can be extremely non-specific, like occasional fatigue, feeling of drained out, weakness, weight gain, corn intolerance, constipation, but that's truly not really there. So obviously, when we look at a TSH which has gone up, there could be two causes. One is a transient rise of TSH, and second could be a persistent rise of TSH. So what are the causes of transient rise of TSH? Any non-thyroid illness, simple flu to any other non-thyroid illness can cause, when the person is convalescing and recovering, can increase TSH. Any simple inflammation of the thyroid gland, typically called thyroiditis, where there is a painful or painless thyroiditis recovering, can cause increased TSH. Simple medicines, sometimes used by psychiatrists to treat mania,
called lithium, or cardiologists which use a pan antiarrhythmic drug, which is the largest content of iodine on planet Earth, called amiodarone, can also rise TSH. And the other common cause of raised TSH is patient never tells you that he has thyroid disorder, has been taking intermittent thyroid or has some malabsorption issues and has been taking thyroid medicine, and that is the time the TSH may be raised. So the causes of transient raise of TSH are recovering from non-thyroidal illness, recovering from thyroiditis, amiodarone, lithium, or maybe a masked. That means patient has not given you the history that he's taking thyroid disorders. The more common is the persistent rise of TSH, where the free T3, free T4 is normal. That could be an adaptation phenomenon. The commonest is our senior citizens. Somebody is 95 or a centenarian, and if the TSH is 7, probably it's a normal variation. Or people who are living in regions where there's a historical iodine deficiency. More iodine deficiency, the higher is the TSH. So if I see somebody in iodine deficient region with a TSH of 6, I would not put too much to it. So it is basically nothing but a physiological adaptation to aging. Second cause of persistent high TSH could be due to heterophile antibody, which is a lab issue. Obesity can cause a little bit of transient persistent TSH elevation, very rarely adrenal insufficiency, and very, very extremely rarely thyroid hormone resistance or thyroid TSH resistance, which normally you should send the patient to an endocrinologist. Most thyroid disorders can be treated by a physician like you, but remember, when you are looking at adrenal disorders or high thyroid hormone resistance, then you should refer your patient to an endocrinologist. Now, typically, does everybody with a TSH progress to hypothyroidism? And the answer to that is no. Not everybody will do. Every year, the progression rate is anywhere from around 2 to 6%. And the risk is more in females. There's a gender bias in thyroid. There is a 8:1 ratio of female to men with thyroid. Individuals with higher TSH, higher the TSH, the more is the likelihood of progression. And if the antibodies are positive, higher is the risk of progression. So if you will want to know if the TSH, the anti-TPO antibody is negative, if you are a male, if your TSH level is 5, it's unlikely to progress. While if you are a female, TSH is around 9, anti-TPO antibody is strongly positive, you are more likely to progress. Well, there's going to be a separate topic on cardiology, and I'm sure the other two speakers of mine, Dr. Prasunadeb and Dr. Ganesh, who are my very close friends, are going to discuss it. But does subclinical hypothyroidism confer a heart risk? It does, probably. The most consistent cardiac abnormality with subclinical hypothyroidism is an impaired LV diastolic function. The results of systolic function are not very consistent. So what is happening? Fundamentally, there is a reduced peripheral action of thyroid hormone. The intracellular calcium handling is weaker, and that is why the heart muscle, which is myocardium, relaxes slowly, and there is LV impaired diastolic filling defect, which is commonly seen. And typically, when a large meta-analysis was done of subclinical hypothyroidism for fatal and non-fatal cardiovascular disease, because we are today in cardiovascular medicine living in an era of outcomes. And a meta-analysis of more than 55,000 patients in 11 prospective studies clearly have shown the cardiovascular morbidity and mortality have been elevated. And here you can see as the TSH tertiles go up, there is a clear cut 1.89, 1.42, 1.58 increase in the cardiovascular morbidity, cardiovascular mortality, and total mortality. So there is clearly an incremental increase in the death risk due to heart disease, total death risk, as well as cardiovascular disease risk when you have a high TSH. And that TSH clearly also is not only responsible for heart disease, but also for heart failure. Now, heart failure has been in vogue, and the risk of heart failure is increased both with higher and lower TSH. So we can see both the extremes here, that lower the TSH, higher is the risk of heart failure. Higher the TSH, more is the risk of heart failure. For the higher TSH, which is our scope of discussion today, the odds ratio is 1.65, which is a 65% increase if the TSH is between 7 to 9.9 with a positive p-value. and a TSH between 10 to 19 of 1.86 and 86% increase. So very clear data there. The other thing which we know that subclinical hypothyroidism has adverse prognosis in heart failure patients. And that's something which we know that there are a lot of studies where there is a decomposition. So whether it's cardiac event or all-cause mortality, TSH has an altered outcome. And here again, you can see a connect between the observational studies where there's a secondary dyslipidemia. As the TSH goes up, always do a lipid profile, always do anti-TPO antibody. If the lipid profile shows an elevated cholesterol, then obviously that is something which is seen with a subclinical hypothyroidism. Your likelihood to treat is more. There's also a direct correlation between carotid intima media thickness, metabolic parameters like lipid parameters, as well as blood pressure. And all these three have a statistical outcome which is pretty positive, and all of them can indirectly link to increase all-cause mortality. So clearly the data which is summarized here by the various studies published across planet Earth, you can see that a high TSH can impact death rate or overall mortality. The other thing is if you leave this untreated, what happens? And this is very well illustrated that if you leave untreated high TSH, it will lead to hypertension, cardiovascular abnormalities, endothelial dysfunction, stiff arteries, and dyslipidemia. And that will indirectly confer an increased risk of cardiovascular mortality and morbidity, whether it is coronary artery disease, heart failure, or atherosclerosis. And that is what I illustrated. The big problem is in our senior citizens and elderly individuals. And that's the place where you have to exercise a lot of caution with this. As I told you, as the age shifts, the bell-shaped curve, which is a normal Gaussian curve of the TSH shifts. And that's we need to recognize that often our senior citizens have a higher TSH tertile and their TSH is above 60 tend to change. So obviously there is an adaptation physiological mechanism with aging, which we need to recognize with thyroid function. So this suggests that a TSH increase rises from age-related alteration of TSH set point or a reduced TSH bioactivity rather than occult thyroid disease. So in a senior citizen, the likelihood of occult thyroid disease is rare. It could just be an altered TSH set point or a reduced TSH bioactivity, which is much more common. So the big question is, should we treat older adults with thyroid hormone therapy with subclinical hypothyroidism? And this was the TRUST trial. And the TRUST trial showed that thyroxine provided no apparent benefits in senior citizens with subclinical hypothyroidism. This was a large European Union study which clearly documented it. So this whole dilemma which is there for subclinical hypothyroidism is to treat or not, don't treat. And that's what we walk in as doctors every day. And these are some guidelines. Thyroxine treatment of subclinical hypothyroidism, its impact on fatal, non-fatal cardiovascular events and mortality. So this was the UK General Practitioners Database. They identified more than 44,700 people with more than 40 years, TSH between 5 and 10, normal free T4. They excluded people who took thyroxine, antithyroid drugs, previous heart disease, previous ISD, stroke, and other vascular disease. And clearly you can see if you treat, fewer cardiovascular events were seen in people who were treated with subclinical hypothyroidism. So between 40 to 70, treat. If in doubt, treat, because there is a outcome which is completely positive, and we are living in a. However, and also you can see between 40 to 70, if you look at not only the cardiovascular mortality, but also the all-cause mortality decreased. And if you treat above 70 years, however, the cardiovascular events go up. So in senior citizens above 70, don't treat, but below between 40 to 70, treat. And again, you can see above 70, the all-cause mortality goes up. Do we have RCTs? Because today we live in an era of RCTs. And we have seen in randomized control trial that if you treat thyroxine alone, do you need to give statin to everybody? No. If you just give simple thyroxine to mild subclinical hypothyroidism, the cholesterol will come down. This is a RCT with thyroxine or no treatment. Clearly a TSH between 4.3 and 10. The thyroxine was very clearly beneficial with a mild TSH increase. with a drop of cholesterol to 15, and that's something which is near. So obviously for non-pregnant adults, because in pregnancy everything is different, there the TSH cut point of 2.5 is very aggressive. For a general therapeutic approach for non-pregnant adults, in view of the data linking subclinical hypothyroidism with atherosclerosis, myocardial infarction, and increased risk of progression, even asymptomatic patients probably should be treated, is what the ATA and the ETA say. So what below 10, whom do you treat? Well, treatment trial is always there when you are in doubt. A TSH which is twofold increase above 8, treat. Progressive TSH increase, treat. Younger patient, treat. Diabetic patient, treat. If pregnancy or intention for pregnancy is there, treat. Presence of goiter, treat. Antibodies, patient preference, cardiovascular risk, dyslipidemia, and if they're infertile or ovulatory dysfunction, treat. So if in doubt, treat. Women of periconceptual age, treat. So be aggressive that time. Okay, so remember whom do you treat and how do you treat. Remember that if the TSH is between zero point 0.4 to 4.4, well, that's the reference range which is normal. Then between 4.5 and 6.9, only treat if there are symptoms, positive antibodies, progressive increase, planning pregnancy or goiter. Otherwise, we may not always recommend if they are below 65 or 70. However, if they are above 75 at 6.9, I will not treat. Between 7 and 9.9, probably, I will treat independent of the age. Because after 7, if you are treated with thyroxine, there's a risk of fatal stroke and heart disease mortality coming down. And even above 65, if above 7 TSH I treat, there's a reduced risk of heart, coronary artery disease mortality. Above 10, clear data to suggest that heart failure risk goes down, coronary artery events goes down, as well as cardiovascular events go down. So treatment of choice is simple thyroxine, the most bioavailable thyroxine which is available first thing in the morning on empty stomach, and we know the dose is 1.6 microgram per kg body weight. Usually without cardiac disease, we start anywhere at 88 is supposed to be the magic dose, which has been devised for Caucasian population. And if there's cardiac disease, start slow with 12.5, 25, and then increase it very gradually. Same thing is with our elderly population. Thyroxine is a very, very key hormone, and it has a direct role on our thyrostatin, our energy homeostasis, and our cardiovascular dynamics. And we know that if we do not appropriately treat at the right time, it will have an impact on vasculature, contractility, and lipids. And therefore, reversing that at the right time, at the right age is very critical. However, if you have senior citizens in borderline situations, probably we may leave them alone. Thank you so much for a patient hearing. I am sure after all the 3 talks, we'll be happy to join for a nice discussion. Thank you.
Thank you, Professor Joshi. It was a very lucid presentation on subclinical hypothyroidism, which confuses many physicians. And you have not only told the approach, you have told the management protocol also. I'm sure there are many questions at the end, and we'll take it in the question answer session after next 2 talks. With permission of Dr. Arul Raj, our chairman, sir, we are moving to the next presentation. It's on cardiovigilance in thyroid disorders by Dr. Prashun Dev. And Dr. Dev is a senior consultant endocrinologist and now HOD Department of Endocrinology at KIMS Hospital, Sikandarabad. He has also served Yashoda Hospital, Hyderabad as head of endocrine. And he has been a faculty in all national and international events. And I'm sure he'll not only present you a very informative talk, but also will take up all your questions at the end. We present you Dr. Prashun Deb for the topic cardiovigilance in thyroid disorders.
Thank you, Dr. Panda, for that introduction. Am I audible? Can you hear me?
Yeah, you're audible, sir.
Right. And could someone? Yes, we have the slides also. So I thank all of you for having me here. The topic that I have today is cardiovigilance in thyroid disorders. So we are going to briefly discuss about hyperthyroidism as well as hypothyroidism in clinical practice. And we'll see how that affects the heart and what, as practicing doctors, we need to be cautious about regarding the heart when we are treating your thyroid patients. Can I have the next slide, please? Can I have the next slide, please? Yeah, thank you. So why is it that we are so worried about the heart? The reason is, as we will see in the next subsequent slides, that the level of thyroid hormone to a large extent also affects the basic functioning of the heart, as well as the heart, the risk factors of the heart in terms of cholesterol, blood pressure, as well as the heart rate per se. And these we are going to discuss when we discuss separately hyper and hypo. But before that, during the embryogenesis, remember that the heart and the thyroid are formed very close to each other. And when they move down into the thorax, because they have this practically common etiology, this is the reason why a number of people can actually, the places where you can have ectopic thyroid tissue includes the myocardium. And because these two organs are so close to each other during embryology, there is also some structural and functional similarities that these two organs have, and we are going to discuss that subsequently. Next slide. This is a rather busy slide, and I'll draw your attention to the top left-hand corner, and this is where we will start. The T3, that is the functional hormone in the body. Remember that both T4 and T3 are manufactured in the thyroid gland. Predominantly T4, a vast majority of the hormone that is synthesized in your thyroid gland is T4. And then it comes out in the body and it's converted to T3. T3 is the active gland, the hormone in the body. And this controls the tissue thermogenesis, the systemic vascular resistance, the afterload, and this has been actually discussed by Dr. Shashank Joshi, cardiac inotropy and chronotropy, that is how hard the heart beats and how fast the heart beats, are all controlled by the thyroid hormone levels. And finally, the cardiac output is also controlled by the thyroid hormone levels. Next slide. A lot of it is common knowledge. We know that hyperthyroidism causes tachycardia and that causes problems. Similarly, hypothyroidism can cause severe bradycardia, and we'll see that hypothyroidism is also associated with coronary artery stenosis because it causes dyslipidemia towards your right. And finally, the hypertension, and this also we will discuss subsequently when we are discussing about hyper and hypothyroidism. Hypertension is also a part of a thyroid cardiac interaction. Next slide, please. Next slide. And this is where the cholesterol is controlled by the thyroid gland. Now, this is also a very busy slide, and I apologize that I do not have a pointer to show you various places. But as you can see, the right side box explains it. Thyroid hormone levels increases the LDL receptor expression. What does the LDL receptor do? You can see that on the top of the liver. It basically clears LDL from the blood. It takes the LDL from the blood and stores it in the liver. So it will reduce the LDL levels at the cost of theoretically producing a fatty liver. It also increases the CETP, and the CETP is responsible for transfer of the bad lipids from various kinds of lipid subfractions. And these levels are also increased because of the thyroid gland. And finally, the hepatic lipase, it's marked as HL in that diagram, is also increased by the thyroid hormone. These effects that thyroid hormone has on various aspects causes certain changes, and we'll see what happens when we have the hypothyroidism. So if you have a hyperthyroid patient, everything that we just discussed goes up, and so the clearance of cholesterol from the blood becomes faster. These patients actually have less total cholesterol, less LDL cholesterol, and less HDL cholesterol, not so much difference in the triglyceride. Compare that to overt hypothyroidism, where everything is opposite. The total cholesterol increases, LDL cholesterol increases, HDL cholesterol not so much, the triglyceride tends to go up, and we have seen that routinely in our practice. Subclinical hypothyroidism will be somewhere in between. It will not be as manifest as the overt hypothyroidism, but the total cholesterol and LDL cholesterol tends to go up because all these factors that the thyroid hormone controls becomes less in the. So first we talk about the hypothyroid heart. And in a nutshell, these are the changes that you expect. Next slide, please. Can you change the slide, please? Yeah. So next slide. Yeah. So in hypothyroid and the heart, next slide. These are the various parameters that we look at. The systemic vascular resistance is increased, and this is the reason why diastolic blood pressure increases in uncontrolled hypothyroidism. The cardiac output, partially because of this increased systemic vascular resistance, goes down. So hypothyroids have a problem of diastolic hypertension as well as their cardiac output becomes less. The systolic blood pressure, on the other hand, is not affected too much. If anything, it might actually come down a little bit, which means that the pulse pressure tends to go down in hypothyroidism. The difference between the systolic and the diastolic blood pressure becomes less. There is a tendency to bradycardia. Dr. Shashank Joshi has already showed you how the cardiac contractility comes down because the calcium influx into the heart muscles goes down in hypothyroids. And so the contractility goes down, and this is another reason why the cardiac output goes down. The cardiac mass decreases and the blood volume decreases. And these are all features which basically gives rise to the various clinical aspects of hypothyroidism. Next slide. Can I have the next slide, please? Yeah. So sinus bradycardia is, of course, something we all know, but we also know that it causes a prolonged QTC. Now, thanks to discussions in a different context where one of the molecules which we routinely use in our clinical practice for treating diabetes is also known to prolonged QTC, and we know by now that it can cause certain dysarrhythmias and can ultimately cause torsades de quondis, which is a fairly serious ventricular tachyarrhythmia. The QRS voltage is traditionally low. So if you see the ECG of a hypothyroid, you can immediately see that the tracings that you have are very small. The voltages are low, and this, among other things, actually masks certain changes which otherwise you would have been able to see if the QRS voltage was not low. Now, it can cause AV block, and if very severe, a serious bradycardia in a hypothyroid presenting to you with mixed edema coma can actually have a patient with complete heart block with a ventricular escape. Intraventricular conduction delay, a left bundle branch block or a right bundle branch block are also fairly common. And so you have lots of abnormalities that you can expect in an untreated hypothyroidism. Next slide. Next slide, please. Yeah. Now, if you take a TSH of between 0.45 and 5, that is at the middle of this graph, and take that as unity, then you'll see that both hypothyroidism, that is when the TSH is going up 7 to 9 or 10 or more, or hyperthyroidism, that is the TSH going down towards the bottom of your chart, the risk for heart failure goes up in both the cases. So a euthyroid patient, if you take it as having a risk of 1, both hyper towards the top of the chart and hypo towards the top of the chart and hyper towards the bottom of the chart, will increase the chances for heart failure. We have just discussed why hypothyroid patients will have heart failure chances increased. Hyperthyroid patients will discuss subsequently, and that is generally because of tachyarrhythmias. Now, subclinical hypothyroidism, this slide has already been discussed. It basically, we know that subclinical hypothyroidism increases the cardiac event rate as well as all-cause mortality, and this is one of the strongest reasons why it is recommended that, especially if you do not have any other risk factors and you have some unexplained cardiac abnormalities, then subclinical hypothyroidism needs to be treated. In fact, if your patient has got a low T3 as well as an ejection fraction which is low, less than 20, then the chances of cardiac mortality is the highest. And this chart shows you that the lowest line on this survival chart has an ejection fraction of less than 20% and a total T3 of less than 1.2. So this is the highest risk group where the ejection fraction is low, the T3 is low, and the survival is the lowest, as you can see. At the opposite end is the people are right at the top, an ejection fraction of more than 20% and a total T3 which is within the normal range. These people have the best survival. Now, the mixed bag is in between. You can see a low T3 actually gives a weaker chance of survival than who have a low total T3 stand actually to have a higher chance of dying of cardiac events if their T3 is low as compared to their ejection fraction being low. Next slide. Next slide. Next slide. Next slide, please. Yeah, this was the thing that I was talking about. As you can see, the lowest line is the ejection fraction of less than 20, a total T3 of less than 1.2. The highest people are the ejection fraction of more than 20 and the total T3 of more than 1.2. Next slide. And not only is the low T3, T4 apparently bad, we now have data that if you treat the T4, if you bring the thyroid levels back to normal, are you making a difference? And data suggests that yes, you are. This data is in subclinical hypothyroid patients who were treated with levothyroxine and their T4 levels brought back to normal. Did it make a difference? As you can see, the total cholesterol and triglyceride are easy to understand. We know that total cholesterol is high and triglyceride is generally high in hypothyroid patients. If you treat them, then it actually makes a difference. It brings down these levels by about 0.53. As you can see at the right side of the column, this is statistically significant. But the carotid intima medial thickness also comes down when you treat these patients with levothyroxine. And this is a very, very strong factor in favor of advising levothyroxine to subclinical hypothyroid patients. Whether you should do it to all the patients, I'm sure we are going to discuss that at the end. Right now, we are only focusing on the cardiac benefits of treating subclinical hypothyroidism. And so, treating hypothyroidism in patients with coronary artery disease, it is important that we treat these patients. However, the only thing that you need to be concerned about, and we always consider that in clinical practice, if you have a patient who actually has an unstable angina, and for some reason you need to start these patients on levothyroxine, you cannot wait to treat the unstable angina. For example, suppose a patient is planned for a coronary artery bypass graft. This patient is symptomatic. He needs a surgery. And then you find out that this patient is also hypothyroid. What do? The surgeon will be not very keen on treating this patient, not operating on this patient because the hypothyroidism is significant. And you know that general anesthesia can be an issue in these patients. And so you need to bring down the TSH levels to within manageable levels. Remember that these patients are actually more prone to having a worsening of their angina if you start on a very high dose with these patients, because the cardiac oxygen requirement actually goes up when you start the levothyroxine. So someone who is already having an ischemic heart, if you start him suddenly on a 75 micrograms levothyroxine, can actually have an angina attack. And especially if a patient is waiting for a CABG, then this is something that you need to worry about. So you need to start with a very small dose and slowly increase the dose over the next days or weeks. And this is probably the only adult patient who can actually start with 12.5 micrograms. Remember that for the vast majority of your patients, if they are adults, 12.5 is hardly a dose. You do not require that for any of your patients. But if your patient already has an angina, then you start with 12.5 and then slowly increase the patient the dose to whatever this patient is required. Next slide. Next slide. Yeah. So you start with 12.5 and then slowly increase the dose. Next slide. Can I have the next slide? Yeah. So cardiac function in subclinical hypothyroidism, again, something that Dr. Shashank Joshi has already talked about, and I'm not going to spend too much time. Can I have the next slide, please? Yeah. This also has been discussed. Now, this basically shows the CHD events and the CHD mortality in patients who have subclinical hypothyroidism. Now, again, you know how to read these charts, and I'll draw your attention to the first cluster right at the top of your slide. If the TSH is between 5 and 0.5, that is the first box, then you consider this as unity. Now compare that with the patients who have subclinical and then finally overt hypothyroidism. You can see that the risk increases exponentially as the TSH starts going up. Patients who have a subclinical hypothyroidism do not seem to have too bad an outcome in this particular chart, but as the TSH goes up to 7 or beyond, and this is still within range of subclinical hypothyroidism, 7 to 10 is within subclinical hypothyroidism, you can see that this has already moved to the right, showing that the risk has increased. Look at the CHD mortality, that is the middle group, the middle circle, and here also you can see till 6.9, the box looks fine, almost the same as 0.5 to 5, but at 7 or higher, the line has already started moving towards the right, and you can see the numbers, the relative risk is 1.42, which is fairly high and statistically significant. Both the numbers are more than 1. So which means that CHD events and CHD mortality has already significantly started getting worse as soon as your patient has a subclinical hypothyroidism. Next slide. The surrogate, next slide please. Yeah, the surrogate markers have not shown this so well, and as you can see, the strength of the association between treating these patients and the surrogate markers is at best weak in terms of risk of coronary heart disease and risk of congestive heart failure, but the risk definitely exists. Next slide. So in summary, next slide please. Yeah, in summary then, hypothyroidism is a risk factor for most of the events that you can think about, and especially congestive heart failure and disease. Next slide. And briefly then, hyperthyroidism is an easier thing to understand. There is a decrease in the vascular resistance. These patients actually have a high output heart, and the cardiac output actually increases. The systolic blood pressure goes up, the diastolic comes down, the pulse pressure increases. These patients' main problem is heart rate. And if you have an increase in the congestive heart failure chance, then it is generally because of the tachyarrhythmia. Plenty of tachyarrhythmias are associated with hypothyroidism. The most important of them is atrial fibrillation. In fact, if you have atrial fibrillation with no other causative agent, lone atrial fibrillation, so to speak about, then you should always check for hyperthyroidism. In Graves' disease, there are other reasons also why you can have atrial fibrillation, inflammation, the antibodies, but it is the high levels of thyroid hormone which can actually be associated with atrial fibrillation, and sometimes treating that can actually treat the atrial fibrillation also. Not only this, the entire new onset atrial fibrillation, as you can see, as the thyroid level goes from hypo to hyper across the board going up, hyperthyroidism clearly has a higher chance of atrial fibrillation. Heart failure in hyperthyroidism, unlike in hypothyroidism, is predominantly rhythm related. So if you have a patient who has tachyarrhythmias, obviously there will be a heart failure in these patients. Treating the tachyarrhythmia can actually help in the heart filling up properly, and these patients can actually be treated simply by managing the hyperthyroidism. Next slide. Next slide, please. Yeah, next slide. Next slide, please. Can I have the, yeah. So we have discussed that. Next slide. Yeah. So this we just discussed. Low atrial fibrillation can cause can be associated with the hyperthyroidism. Next slide, please. We have discussed this also. Next slide, please. Next slide. So then, in hyperthyroidism, the heart failure is generally because of tachyarrhythmia. As you can see, the myocardial contractility is actually better in hyperthyroidism. There is an increased myocardial contractility, and these patients generally have heart failure because of the rate abnormality. Next slide. Next slide, please. So the clinical practice suggestions suggest that whatever heart problem you have, you should always look at the thyroid levels. Both hypo and hyper can actually cause congestive heart failure, and sometimes simply treating the high or low thyroid can actually improve the cardiac outcome. Next slide. Pulmonary hypertension is something that is associated with hyperthyroidism. Treating the hyperthyroidism can actually improve this. Next slide. And so is pulmonary embolism. We know that if there is a clot in the heart and there is a tachyarrhythmia, then there is a very high chance that the clot will dislodge and then cause pulmonary thromboembolism. And this is more common in hyperthyroidism. And so if you have a patient of pulmonary thromboembolism, again, it's a good idea to check for the cardiac function, the thyroid function. Next slide. In summary then, a hyperthyroid heart is basically because of the hyperdynamic and tachyarrhythmic circulation that you have. Treating the hyperthyroidism takes care of both this hyperdynamic circulation as well as the tachyarrhythmia. Next slide. And that's my last slide. Take home messages then. Thyroid and cardiac functions are intimately related. They originate at the same place, and the levels of one actually controls the cardiac function. And when you have thyroid dysfunction, or you know or you suspect thyroid dysfunction, cardiac disease or risk should persist. When you have cardiovascular disease, you should actually look for thyroid disorder, and if it is there, you should treat it. Lastly, subclinical thyroid dysfunction can also be associated with cardiac disorders, and it merits clinical screening in all cardiac patients. I'll stop here. If there's any questions, we can take it later. Thank you.
Thank you, Dr. Prashun Dev. It was a complete presentation, and many physicians know that there is an association of hypothyroid as well as hyperthyroid state along with the cardiac complications. But you have lucidly told the complications exactly in terms of the rhythm disturbances, heart failure, pericardial diseases, and other problems. And nicely, you have told the approach to both the issues, and we'll take up the questions at the end. I'm sure there will be many questions. Thank you again for that lucid presentation and completing in time. We'll move on with the permission of our President and Chairman of the session, Dr. Arul Raj. I'll invite our next speaker, Dr. H.K. Ganesh. And you know, Dr. Ganesh is a professor and head Department of Endocrinology, Diabetes and Metabolism at AJ Institute of Medical Sciences at Bangalore. And he is not only recipient of A.R. Shet Award for Best Original Research Award in Endocrinology, but has several papers in the national and international journal, and member of Endocrine Society of USA, RSSDI, AAC, API, as well as ESI. And he has been a faculty in all national and international programs. And his topic is also very interesting regarding anti-thyroid drug. Many are confused regarding how much and how long. And for the topic, Dr. H.K. Ganesh is coming for next 20 minutes. So we present you Dr. H.K. Ganesh, our endocrinologist. Dr. Ganesh, please.
Thank you. At the outset, I would like to thank the organizers, API DIAS, and Abbott team for inviting me to give this talk. For the next 20 to 25 minutes, I'll be not 25 minutes, I can finish in 20 minutes regarding anti-thyroid drugs, how much and how long. This topic was made possible because of these great gentlemen, the McKenzie's and Richter et al. They found that certain insecticides, rather rodenticides, can be goitrogenic. When they were used, the rats developed goiters. So that's how the anti-thyroid drugs were discovered. So McKenzie's explained that goiter was likely due to inhibition of the thyroid hormone synthesis, and because of this great gentleman, Edwin Bennett Astwood, so he successfully used these agents in his 3 hyperthyroid patients. One he treated one with thiourea and 2 with thiouracil, and later in 1949, methimazole was discovered, and it was found to be even more potent and less toxic than thiourea analog. So this Astwood published the papers in Journal of Clinical Endocrinology in June 1944, and he used 0.2 to 0.6 grams of thiourea, and at that time only he found that granulocytopenia can be a side effect of the thiourea group of drugs, and he observed that adequate treatment continued for longer than 6 months was attended by high incidence of remissions. Mind you, this was in 1944, approximately 80 years back. At that time only, Astwood pointed that the time will not be long before the common practice of ablating the thyroid will pass into the history. This is a great discovery. So even now, we are continuing the same. So let me start with the case capsule. 40-year-old gentleman with the symptoms of toxicosis since the last 4 to 5 months. He has significant weight loss, and we can see here he has a staring look, moderate inactive ophthalmopathy. So his thyroid function goes like this: T3 of 650, T4 of 24.6, and TSH suppressed 0.001. You can see the biochemical values. So the diagnosis is simple. So when a patient presents with ophthalmopathy, you don't need other investigations like technician scan. The diagnosis is well written on his face. So it's Graves' disease with the moderate inactive ophthalmopathy. So what are the management strategies in such kind of patients? We have mainly 3 sets of management what we can do here. One is medical management, second is radioactive therapy, and third is surgical removal. So medical management, we can control hyperthyroidism with whatever I have discussed just now, thionamide class of drugs, carbimazole, methimazole, or propylthiouracil, or we can control the symptoms with beta blockers, and beta blockers are contraindicated with calcium channel blockers. We can go for radioiodine ablation also, especially in toxic maternal goiter and Graves' disease, particularly who have relapsed. And surgical therapy is indicated only in very few Graves' disease or Graves' disease patients. Toxic maternal goiters or AFT, and if they are very, very large, then we can go for surgical modality. Otherwise, hyperthyroidism more or less can be managed mainly by physicians and endocrinologists. Surgery colleagues are not at all required nowadays, unless the goiter size is very, very large. So why should we go for the medical management at all? So this is the only form of therapy correcting the basic pathology, because we know the Graves' disease is due to the TSH receptor antibodies or the thyroid TSH stimulating immunoglobulins. So this is the only form of management. Medical management is the only form of management which corrects the this immunity related issues. Chance of complete cure without hypothyroidism, the chances are much higher compared to surgery or radioiodine therapy. And when the T4 or T3 levels are very high, so when the patient is really toxic, it's risky to ablate the patient with radioiodine, or even surgery is even more riskier. So that is the reason. So medical management is the best management when the T3, T4 levels are very high. What are the advantages of medical management over radioiodine therapy? Once again, the hypothyroidism chances are lesser. It's safe during pregnancy, lactation, and Graves' ophthalmopathy. Radioiodine we can't give in these situations. Children with Graves' disease we can't give radioiodine, and permanent cure. And if you give radioiodine, the transplant further, if the woman develops pregnancy, the transplacental transmission of antibodies is still possible. But if the woman gets cured with the antithyroid drugs, that possibility is also not there. What are the advantages of core surgery? Very, very obvious. Less incidence of permanent hypothyroidism, less expensive, no chance of hypoparathyroidism or recurrent laryngeal or palsy, and even complications of general anesthesia can be avoided. So that was regarding the medical management, why it should be chosen as the first line of therapy in management of Graves' disease. So then let us look into which drug. So mainly we have two classes of drugs. One is carbimazole and methimazole, and second is propylthiouracil. Carbimazole and methimazole are almost same. Methimazole is the active drug of carbimazole. So carbimazole 10 mg is equivalent to approximately 6 milligram of methimazole. So there is active intrathyroidal accumulation of carbimazole and methimazole. So that is the reason, even though the half-life is 6 to 8 hours, we can give carbimazole and methimazole in once daily dosing. So the compliance will be much better when we give medication once daily. Propylthiouracil has to be given 3 times daily. Carbimazole or methimazole is cheaper compared to PTU, and reactions are also much lesser and less serious compared to propylthiouracil. Propylthiouracil, of late, many incidences of fulminant hepatitis have been noted, and that is the reason it is absolutely contraindicated in children below the age of 12 years. So the normalization of T4 is also much earlier and rapid with carbimazole and methimazole compared to PTU. And if we are planning for radioiodine therapy in the future, the efficacy will be reduced with PTU, not to that extent by carbimazole or methimazole. So looking at this table, we can clearly say that carbimazole or methimazole is the winner compared to PTU. Coming to the starting dose of carbimazole or methimazole, this is published in Thyroid 2016 ATA guidelines. So we can see we can choose this as an approximate guideline. If the T4 or free T4 level is 1 to 1.5 times the upper limit of normal, so let us say the 12 microgram per deciliter is upper limit of normal. So 12 to 18, if the T4 is 12 to 18, we can use carbimazole in the range of 10 to 15 milligram, and 12 to 18 if the T4, we can use methimazole in 5 to 10 milligram. Similarly, PTU 100 to 200. And if the T4 or free T4 elevation is 1.5 to 2 times the upper limit of normal, the carbimazole dose will be 15 to 30 milligram, and methimazole would be 10 to 20 milligram. And if the T4 or free T4 elevation is 2 to 3 times the upper limit of normal, carbimazole dosage will be 40 to 60, and methimazole will be 30 to 40. So this was published in ATA guidelines, Thyroid 2016. This is the journal's name. You can go through in detail. Very beautiful article given in this. So coming to the case, our case again. So T3, T4 high and TSH suppressed. We started him on according to the guidelines, whatever the T4 is 2 times the upper limit of normal. We started him on methimazole 30 milligram per day and beta blocker propranolol 30 milligram per day. So how do we follow up? Once we start these antithyroid drugs, how do we follow up? Usually the clinical symptoms, there will be improvement in clinical symptoms, especially if we are using propranolol or beta blockers, there will be clinical improvement in 3 weeks, and T3, T4 levels will be improved in 4 to 6 weeks. And very, very important point, what we have to remember, TSH should not be used for monitoring in the early treatment period, because the TSH remains suppressed for many months after starting treatment. Hypothalamo pituitary thyroid axis, the normalization of that takes long time. So it might take 3 to 6 months or even more than that. So that is the reason initial 4 to 6 weeks or up to 3 months, we have to monitor with T4 levels, ideally T4 or free T4, because the T3, there are a lot of biological variation with various assays. So that is the reason T4 or free T4 levels should be the monitoring tool. And the dose of carbimazole or methimazole should be stepped up or down depending on the clinical features and T3, T4 levels. And with every follow-up, we are supposed to down titrate the dosage of carbimazole or methimazole, and we have to maintain the dosage in the 2.5 to 5 milligram, the minimal dosage, for at least 6 months before withdrawing the drug. So once the TSH is normalized, which usually takes 6 months, so after that you can monitor with the TSH. T4 and TSH you can use as a monitoring tool. Once the TSH is normalized, you have to continue it at least for 6 months before withdrawing the drug. Total duration of therapy, I'll come to it. It will be approximately 12 to 18 months. Let us look into some of the studies. What is the duration of therapy should be? So the topic is how much and how long. So this is regarding how long. So duration of antithyroid therapy. So we can see here the various studies. These are the number in the parentheses are the brackets are the months of therapy, and this is the relapse rate. We can see between 12 to 24 months, 6 to 12 months, or 18 to 42 months, there is no much difference. So the relapse rates are almost similar. But in this study published by Alanik et al., we can see between 6 and 18 months, there is huge difference in the relapse rates. That's why it was considered that duration of therapy should be at least 18 months, 12 to 18 months should be the duration of therapy. And toxic multinodular goiter and EFTN, there is nothing like remission. They will not be going into remission. Either we have to go for definitive therapy, or if the patients are definitive therapy like in the form of surgery or radioiodine ablation. If they are not willing for definitive therapy, we'll have to go for lifelong antithyroid drugs in the minimal possible dosage. Our man, with the thyrotoxicosis due to Graves' disease, we continued. So we can see here, we started with the 30 milligram. The second visit, from T4 24, it came down to 12. So we reduced the dose to 15 mg. And the third visit, after the 3 months, the 12.1, it became 9.4. But TSH remained suppressed, 0.01. Still, we reduced the dose to 10 milligram per day. And in the fourth visit, after approximately 6 months, so still the TSH is suppressed, and T4 is 8.9. We continued the dose of 10 milligram per day, and at the end of 9 months, the TSH normalized 1.3 and T4 7.4. So we reduced the dose to 5 milligram per day, and finally we continued 5 milligram for another 8 to 9 months, and we continued the total duration of therapy for 21 months. So American Thyroid Association guidelines clearly says that if methimazole is chosen as the primary therapy for Graves' disease, the medication should be continued for approximately 12 to 18 months. They also state that it can be discontinued if the TSH and TSH receptor antibody TRAB levels are normal at that time. But in India, because of the economic or financial issues, TRAB is very costly. So majority of the labs will charge 5,000 to 6,000 rupees. So probably at this point of time, probably in the future, the kits might become cheaper and we might use in most of our patients. But as of now, TRAB levels cannot be done in all patients. So we are using only TSH. But if TRAB levels become cheaper, then we have to use TRAB levels, TSH receptor antibody levels, and it has to be normal or a very low level before discontinuing antithyroid drugs. Coming to the definitions of remission, relapse, and recurrence. Remission is defined as maintenance of biochemical euthyroidism at least 1 year after stopping antithyroid drugs, and relapse, return of hyperthyroidism within 3 months of antithyroid drug discontinuation, and recurrence if hyperthyroidism develops within 3 months after stopping antithyroid drugs. Remission rates are 50% approximately, but they vary depending on the clinical and geographical locations. Clinical variability as well as geographical locations, it vary depending on the iodination status of the population. All these things matter. So it will vary, but people who have undergone remission, in them also, 1/3 will remain in permanent remission, 1/3 can go into permanent hypothyroidism, and 1/3 there will be recurrence again. What are the factors predicting failure? These are the factors predicting failure, not success. So unlikely to go into remission. Male sex, younger age of onset of hyperthyroidism, longer time for normalization of TSH receptor antibody, persistence of a palpable goiter. These are the factors predicting failure as per David Cooper in the latest clinical thyroidology issues. And according to him, degree of thyroid dysfunction, thyroid volume, and TSH receptor antibody levels per se are not useful for factors predicting failure. So initial TRAB levels or thyroid volume or degree of thyroid dysfunction doesn't matter. Persistence of palpable goiter or longer time for normalization of TRAB are hints for failure. So once again, if we do TSH receptor antibody levels regularly, we can see 3 types of patients. One is smoldering course, and the TRAB titer remains high, very unlikely to remit. Another one is fluctuating course. Some of them can go into remission, some of them can remain hyperthyroid, and recurrence is more in this group of patients. And the third, in remission, the TRAB levels become low. Such patients are more likely to undergo remission. The TRAB is very, very extremely useful in the management of hyperthyroidism. Unfortunately, as I already mentioned, it's expensive. So ideally, we have to measure TRAB at diagnosis at 12 to 18 months. At the end of 12 months, 1 year and 1.5 years, we are supposed to measure the TRAB levels. That TRAB cutoff of 7.5 and 3.85. 7.5 at 12 months at the end of 1 year, and 3.85 at the end of 18 months have good specificity and positive predictive value for relapse of Graves' disease. Higher the TRAB value, higher the chance of relapse. So what about definitive therapy? Definitive therapy like radioiodine therapy should be considered strongly at the time of initial diagnosis, or if TRAB titers persist for more than 2 years of antithyroid drug therapy in elderly, because the potentially life-threatening cardiovascular complications, as Dr. Prasundev was already mentioning, the tachyarrhythmias, which can lead to heart failure. Definitive therapy should be considered in patients who are elderly. And one more issue is osteoporosis in this group of patients. Coming back to the patient whom we have discussed, we have finished 21 months of therapy. He was doing well. He was happy. He comes back after 4 months after stopping methimazole. Let us see what is his values. He already has symptoms, all symptoms of toxicosis. He has regained it. All tremors, palpitations, sweating, heat intolerance, everything he has, and the values are like this. So T3 high, T4 high, 321 and 16.8, TSS suppressed. What to do now? So we have offered him radioiodine ablation as a modality of treatment because he doesn't have severe or active ophthalmopathy. It's inactive ophthalmopathy, so the radioiodine ablation is still possible. So, but he is not keen on going for either surgery or radioiodine therapy. So what about long-term antithyroid drugs? In patients with Graves' disease, remissions do occur after 4 to 11 years of antithyroid drug therapy. So now the data is coming up regarding long-term antithyroid drug therapy. In patients hoping to avoid ablative therapy who are not keen, continuous ATD, antithyroid drug therapy for more than 5 years is reasonable. This is again by Cooper in Clinical Thyroidology 2019. So long-term ATD can be considered in people who are not willing for definitive treatment. Because the chance of adverse effects on a low dose of methimazole, that is around 5 to 10 milligram per day of methimazole, is very extremely low. The adverse effects usually happen within the first 3 months of therapy. Agranulocytosis or other hepatitis, all these issues usually happen in the first 3 months of therapy. So that is the reason long-term low dose of methimazole is an attractive option for the treatment of Graves' disease. So, any evidences? Yes, there are a lot of evidences. This is published in European Journal of Endocrinology way back in 2005. So, effect of long-term continuous methimazole treatment of hyperthyroidism. You can see here, long-term continuous treatment of hyperthyroidism with the methimazole is safe, and the complications and the expense of treatment do not exceed those of radioiodine therapy. Again, one more article published in Thyroid, long-term ATD treatment is effective and safe in adults, and I will not go into the details, but the quality of life scores were worse in patients with Graves' disease treated with radioiodine therapy compared to antithyroid drugs or surgery at the end of 6 to 10 years after treatment. We don't know the exact reason, but in this study, the people who had radioiodine therapy, the quality of life scores were lesser. So this is a comparison between long-term antithyroid drugs versus radioiodine therapy. The cost it can become almost the same if we take everything into consideration, like the frequent follow-up, then the cost of medication, everything. But this one literature, radioiodine, according to the cost of radioiodine, it might become lesser also. Hypothyroidism chances are lesser with long-term antithyroid drugs. Euthyroidism maintenance is better, and weight gain is lesser in long-term antithyroid drugs. Orbitopathy deterioration is also lesser with the long-term antithyroid drugs, and quality of life is better. So the 2016 American Thyroid Association guidelines say that continued low-dose methimazole treatment for longer than 12 to 18 months may be considered in patients not in remission and who prefer this approach, who prefer to continue antithyroid drugs rather than going for ablative therapy. And long-term antithyroid drugs, this is also very, very important slide. We have to remember, long-term antithyroid drugs are not advisable in patients who are requiring high antithyroid drug dosage. People who are requiring very high antithyroid drugs, more than 30 milligram or 40 milligram per day of methimazole, and who are having brittle cores, very small dosage alteration, like 5 milligram of methimazole you are changing, and the thyroid function fluctuates. In such patients, antithyroid drugs long-term is not advisable. Women who are planning to conceive in the near future, it's long-term antithyroid drugs is not advisable. Coexistent cardiovascular disease or tachyarrhythmias, and people who are non-compliant. So these are the group of patients whom antithyroid drug therapy long-term is not advisable. And in pregnancy, Graves' disease, usually improves during pregnancy, like all other autoimmune diseases. Well, if the Graves' disease is well controlled before conception, majority of the patients, it's possible to stop antithyroid drugs. And new onset of thyrotoxicosis always have to be differentiated from physiological changes and gestational toxicosis. And we have to remember that new onset of hyperthyroidism or Graves' disease is not common during pregnancy. So we have to differentiate from gestational toxicosis. And monitoring should always be based on free T4, and free T4 should be kept in the upper limit of normal during pregnancy. And minimum possible dosage of antithyroid drug to be used. And it's possible to discontinue antithyroid drugs in 30 to 50% of patients in pregnant women in third trimester. So which drug in pregnancy? Once again, a difficult question to answer. But methimazole is known to, carbimazole or methimazole is known to produce severe teratogenicity like choanal atresia, which can be fatal, life-threatening. Choanal atresia, esophageal atresia, aplasia cutis. These can happen with the methimazole, whereas PTU produces teratogenicity much, but it is less severe intensity. So probably that is the reason PTU is the preferred in first trimester of pregnancy, and methimazole is preferred in second and third trimester. So if possible, we can shift from PTU to methimazole in the second trimester if you are using PTU in the first trimester. Lactation, again, methimazole is preferred because of the severe adverse reactions like fulminant hepatitis with the PTU, but methimazole maximum dose approved in lactation is 20 milligram per day because it transfers through breast milk. So coming to last two slides, multinodular goiter with last 2-3 slides, multinodular goiter with toxicosis. Best is to go for a definitive treatment like either thyroidectomy or radioiodine therapy. But long-term antithyroid drugs can be continued if the patients are not keen on surgery. There are studies which show that a long-term antithyroid drug is safer. So this is one study published in 2019. So 130 consecutive patients were given either long-term ATD or radiotidine. You can see the results are almost same or better in methimazole group. 96% in methimazole group remain euthyroid, but in radioiodine group, 41% had become hypothyroid and 22% had persistence or recurrence of hyperthyroidism. So long-term low-dose methimazole treatment is safe and effective method for treatment of toxic multinodular goiter, and is an effective alternative for radioiodine treatment. So one more last option, cause of hyperthyroidism, that is autonomously functioning thyroid nodule. Once again, surgery or radioiodine therapy. Radioiodine therapy is the best modality for treating autonomously functioning thyroid nodule because 70% of the patients can become euthyroid depending on the size of the nodule. But if the patients are not willing, still we can go for long-term antithyroid drugs. So concluding my talk, dose of methimazole or carbimazole we should use depending on the severity and clinical status of the patient. Minimum dose 5 milligram per day we have to continue at least for 6 months after TSH normalization. Usual approved duration of therapy is 12 to 18 months. And if the patients are not willing for ablative therapy, long-term antithyroid drug therapy seems to be an attractive option. Thank you.
Thank you, Dr. H.K. Ganesh. That was a very nice presentation on antithyroid drops, and you have covered all the special situations, all the age groups, and very well answered the question, how long and how much. So thank you again. With this, we complete all three presentations. I request our Honorable Chairperson, the President of API, Dr. Arul Raj, to summarize so that we can go to the question and answer session next. Professor Arul Raj. Sir, please unmute yourself.
It's going well, Panda. You can go ahead with the now excellent presentations. You can go ahead with the question answer and close it. Time is up.
Thank you, sir. Thank you for that comment. And we are watching that you are constantly observing everything. And it was a very nice presentation by all three speakers.
Excellent presentations. I should give my appreciations to all the three.
Sir, very, very nice presentations as we all are updated even. And Professor Shashank Joshi, Dr. Prashun Dev and Dr. H.K. Ganesh have done their best. And we have got the best knowledge and information. So also all the physicians who are connected today will get it. And I thank all the speakers on behalf of API DIAS. And I thank for their nice presentation. And with this, I invite our dynamic secretary, Dr. Mangesh Tiwashkar, to take up the question and answer session. I'm sure there are many questions to all three speakers. I request the speakers to please unmute, and I request Mangesh to please put the question to the speaker, and the next 20-25 minutes we have question and answer session. Dr. Mangesh Tiwashkar.
Wow, thank you. And what I can say, amazingly brilliant. So for today's all three speakers, I have learned three new words. Okay, Shashank, as usual, you are intensely clairvoyant. Prasun, you were dazzlingly coruscating. And Dr. Ganesh, you were vividly effluent. The new words that I've learned from you, and it's like amazing the way you have. And there are almost 50 questions. Now allow me to look at my mobile and to throw 50 questions at you guys. And thank you all the participants, the delegates. I'm very happy to say that today API DIAS has crossed the national boundaries. Now it's been seen today in Sri Lanka, Bangladesh, Nepal, Maldives, Bhutan, and we have more than 5,500 participants for this program. So thank you for your brilliant presentations. So first question to Shashank, as you talked about subclinical hypothyroidism, and it's probably a sort of a pandemic-like scenario in not only India but planet Earth, that your favorite word is. So is it imperative for all of us to screen all type 2 diabetics for the presence of subclinical hypothyroidism? And if yes, what are those things that you would be very careful of? You need to unmute, Shashank. You're still muted. I mean. You're not audible. No. Yeah. Yeah. No. Support. Can anybody help Dr. Shashank, please? Till the time Shashank comes back and joins us, Prasun, I have a question for you.
Yeah.
You talked about the risk of cardiac complications and all that, but is thyroid screening recommended for the patients, those who have got hypertension as well?
Hypertension, not so much, because essential hypertension still remains very high on the list of probabilities. And if you are looking for secondary causes for hypertension, if you think that there is something else which is causing the hypertension, then hypothyroidism does not figure very high on that list. Now, it is true that most hypothyroids will have slightly elevated systolic blood pressures, but that is not the thing that you will first think about. So hypertension per se, I do not think that you will look for hypothyroidism too much. However, having said that, it is such a common problem that if you are looking at the routine tests for your patient who has come to you with any kind of comorbidity, I think all of us will do a TSH, though we don't seriously expect that all our hypertension patients will have hypothyroidism. So
Yeah.
do a TSH, but don't expect
Yes,
that
you are
hypertension.
audible. You are audible, Shashank. Yeah, I'm sorry, Prasun. I'm sorry.
No, go ahead.
Yeah.
Go ahead with the.
So
Let continue.
yeah, just that. If you have hypertension per se, no other cardiac comorbidities, it is probably a good idea to do a TSH for everyone who comes to your clinic. But I do not think that hypothyroidism will be very high on the list of probabilities for cause for hypertension.
Yeah, thank you, Dr. Prasun. Now, Dr. Ganesh, I have a question for you. How
Yes.
frequently we use the combination of both methimazole and propylthiouracil together, and have you seen any side effects of this combination?
Methimazole and PTU need not be used together, sir, because the modality of action is almost same. So I think one of them can be used, preferably methimazole. Should be used only in the first trimester of pregnancy. So because it will be just like using glimepiride and glibenclamide or gliclazide in the same patient. So it need not be used in the same patient. I think only one of them should be used.
Okay, thank you, sir. Shashank, now as you are joined back, I would like to ask the same question again, repeat the same question again. That is it important and imperative for all of us to screen all the type 2 diabetics for the presence of thyroid dysfunction? And if it also, how frequent?
So for type 1 diabetes, you should screen every year, because type 1 diabetes is autoimmune disorder, and hypothyroidism is also autoimmune. So for type 1 diabetes, the guideline is global and clear cut. For type 2 diabetes, the guideline is not there. No guideline recommends that you should screen, but we recommend that at diagnosis and afterwards, if you suspect, you should screen, because there is a twin pandemic or twin epidemic of thyroid and diabetes, which often occurs together. So it is prudent to screen, because there is a link between type 2 diabetes and hypothyroidism. But most guidelines are silent how frequently should be the screening. So it should be more of a need-based screening. I do it as a routine because I'm into a tertiary care, referral endocrine center, and that is why a TSHSA is a part of our screening program. However, the guidance from ATA, ETA, even Indian Thyroid Society is open, but we recommend that a screening is desirable. As far as type 1 is concerned, every year it is mandatory. As far as type 2 is concerned, it is preferable desire because you will pick up a lot of that. Particularly, it is more useful in the population because there is some data to show that there is a linkage with complications of type 2 diabetes and TSH, like retinopathy, like nephropathy. So, retino-renal implications are clearly there, and there are some very elegant studies to show that a subclinical hypothyroid or a high TSH might have a retinal or renal link, and which is why I feel in type 2 diabetes, particularly because of the complication risk the thyroid TSH confers, it is prudent to screen and prudent to monitor TSH, probably annually or maybe once in 3 years. Based on it, if the complications are there, probably I would screen every year.
Yeah, thank you, Shashank. Now it's a very interesting question to Dr. Prasoon. We have seen isolated elevation of T4 quite frequently with no symptoms. But if the patients present to you with symptoms like palpitations, will you treat this isolated elevation of T4?
You will need to find out why this is happening. A very common situation would be that the patient was already taking levothyroxine and has been inadvertently taking a little higher dose in the last few days. And the first thing that you will see is that the T4 will go up. It might not have been a long enough period for the TSH to have suppressed. So in the initial phases, if the dose has recently been increased by his treating physician, the T4 can be high and the T3 and the TSH will not reflect into that. The second could be someone who has deliberately taken a high dose of levothyroxine. And this would hardly cause major health issues, but a patient can actually intentionally take 12 or 15 tablets of levothyroxine, and they will present to you with symptoms of hyperthyroidism, and yet the T3 or the TSH will not reflect because it has been an acute elevation. For all other patients, if the patient is not clinically significant or the patient is not been on levothyroxine, then it is probably a good idea to just wait. Uh, Repeat the test again after 2 weeks. It could be a passing phase. It could be, an upgoing or downgoing phase of a subacute thyroiditis where the T4 is high, but the others have not yet sort of played catch up, or it was hypothyroidism and now the body is recovering from, say, a sick euthyroid syndrome where the T4 is the first thing that will go up. And so for these patients, if the patient is not symptomatic, don't immediately jump into treatment. Wait for 2 weeks, do a T3, T4, TSH again, and that will give you a better picture as to where the disease is going, and then treat it. If the patient is symptomatic at that point of time, then also you probably just need to give some beta blockers and wait for the complete disease to manifest. It's probably not a good idea to just treat an isolated T4.
Thank you. Thank you. I believe Dr. Manish Kumar, this question was from Dr. Manish Kumar. I believe you got your phenomenal answer. Now, Shashank, there is a very interesting question for you specifically. This is from Dr. Kaluram Sharma. He wants to know, as there is an increased incidence of thyroid disease, how about is there any role of increase in the use of underground water? Now, I don't know what he exactly means, but there's a specific question which has been addressed to you. Role of underground water and the thyroid disease today.
So I probably know the reason why he has asked the question.
Yeah.
But currently, you see, the point is that a lot of water has admixture of fluoride. So Dr. Bavaskar from Mahad published some data a couple of years back, almost 15 years back, where he actually documented a mini, endemic area of hypothyroidism where the water content was not appropriate, and there was a lot of the tube wells which are not appropriately built had some fluoride contamination. So it is more linked to fluoride contamination and decontamination and fluorosis, and less linked to thyroid and iodine directly. There are iodine insufficient areas also. But if you ask me very honestly, uh, three places water used to be recommended. In the good old days, we used to have iodide filters, and those iodide filters used to interfere with TSH assay. And that is far more common in clinical practice. And that's why often sometimes we tell patients to have boiled water or mineral water, because sometimes some of the filters can have a challenge with that. Second is, as far as apart from that, any other water is concerned, as long as you boil it, we are good on it. And I would not put too much to it, but there is a fluoride iodine thyroid connect, but that is a ill-researched connect, and there is no public health recommendation, and actually there is no dietary recommendation. Occasionally we tell in goitrogens to be avoided in people who have goiter, but as far as water is concerned, except for those iodide filters which interfere with assay, I would not give any recommendation on the hard water which is alluding to. Yes, there has been some scanty data, but this is an unanswered research mode area question. And currently the public policy, the government of India has an iodine deficiency program which is still ongoing, and we still have districts in India which have suboptimal iodine deficiency. And even today, as we talk, cretins are born in India, which is not good, which is iodine deficiency related. And we have a World Iodine Day. We have an iodine is the best micronutrient for brain development, as we know. And therefore, our whole idea, and it is the most common cause of reversible mental retardation. And therefore, it is important and imperative to understand that iodinization will continue, and we want clean water, but clean water has no direct link with thyroid disease.
Yeah. Thank you, Shashank. In fact, let me
Dr.
come to Dr.
Joshi,
Prasoon. Yeah, Dr. Prasoon, I'll come to you.
Could I just have one small addition to that?
Yeah, please.
In the sub Himalayas foothills, there are some areas where the native water has got goitrogens in it, and that is probably the only place where you have to be a little cautious about the groundwater. So thiocyanates and perchlorates are something that you have in the northern part of Uttar Pradesh in the sub-Himalayan foothills, and these are the areas where goiter is fairly common in the population. And so it's probably a good idea for these people not to use the groundwater without boiling them, as Dr. Joshi has pointed out. But that's not because of the iodine; it's because of the goitrogens in the water.
Correct. And many of these food compounds also have it, like cabbage, cauliflower, soya, prawn, shellfish, crabs, and broccoli.
Yes.
They are all goitrogens, and many of them need to be avoided. I totally buy your point, and they have a lot of thiocyanates. But as I said, this is a research mode area, and probably just boiling the water does away with all of that.
Yeah, fantastic. And thank you, Dr. Kaluram, for asking that question. And let me tell all the viewers, very few must be aware about it, that Shashank is a very avid worker in the environmental health. And along with Professor Dr. Mohanty, me and Dr. Agam Vora, Shashank has been one of the most active, I would say, advocate of a very healthy environment. And there is a medical association which is also called as Environmental Medical Association, where Shashank is a very active member of that. And his talks on pollution and endocrine disruptors in the environmental, in the environmental disgrace are phenomenal and worth listening. I'd request Shashank sometimes to give you a talk, give us the guidance on that. Now, Dr. Ganesh, there is a question from you, for you. And this question is from Dr. Praveen Gupta. And he wants to know, you have initiated the therapy of neomercazole or propylthiouracil, and how frequently you will monitor TSH, and how would you titrate the dose accordingly?
Yeah.
And
So
which is
the
maximum cutoff dosages that you would see for?
Yeah, the first visit usually I call is after 3 to 6 weeks. Ideally, we have to call after 3 weeks, but because of the various reasons, I usually call after 6 weeks. That is 1.5 months. So at that time, the majority I will be mainly looking at the T4, because the T4 will be the major hormone according to which I will be making the dosage adjustment. T3 also should be asked, because some of the multinodular goiters, there can be a T3 toxicosis, and T3 will be the predominant hormone. But there are a lot of issues with the T3 assays. Since the calibration has to be done on daily basis with the majority of the T3 assays, so it's not properly done. So that's why all T3 values you have to take with a pinch of salt. So the T4 and TSH should be the first hormone to be assessed after 6 weeks. And after that, the next visit should be again 1.5 months. That is at the end of 3 months of therapy. So after that, so once the TSH is normalized, that usually takes up to 6 months. In majority of the patients, it takes 3 to 6 months. So in some, it can go up to 9 months also. So after that, once the TSH is normalized, you can monitor based on TSH. So at least once in 3 months, the patient has to come for visit. So we have to follow up like this 12 to 18 months. So we have to continue minimum dosage of carbimazole or methimazole. So for a minimum duration of 12 to 18 months, then if the TSH is normal at least for 6 months, then we can stop carbimazole or methimazole. So I think we have to be very clear. So unless there is a clear-cut indication, we should not use PTU because PTU is found to be a little more hepatotoxic. So it should be either carbimazole or methimazole only.
And friends, as you increase the dosages of these antithyroid drugs, you need to be very, very cautious about the bone marrow. Keep your watch on your bone marrow, especially bone marrow depression and leukocytopenia is an extremely common phenomenon with the higher dosages as you probably cross 25 or 30 milligrams of methimazole or higher doses of propylthiouracil. Now, Dr. Prasoon, there is a question from, I'm not getting the name of the doctor here, but he has asked, I have a patient of an atrial fibrillation who is on the dose of Eltroxin, sorry, I should not be using the generic names, but the trend names I should be. Levothyroxine is on with 150 milligrams, 150 micrograms, and still her TSH is not getting under control. What next you would advise?
The first thing that you need to ensure is compliance. The commonest reason why you do not get what you want, or you got it and then the thyroid has suddenly started worsening, is that the patient is not taking the tablet properly. So make sure that someone else in the family is in charge of this, or you could actually count the tablets and find out whether the patient has taken the tablets regularly. Tell him not to miss the tablet any day. If he has forgotten it in the morning, tell him to take it any time of the day. If he has forgotten it the entire day, tell him to take double dose on the next day. But make sure that the patient is taking about 30 tablets every month. Otherwise, this is a fairly common thing that you keep increasing the dose and the patient just simply doesn't take it. The other reasons for this are not so common. It could be a kind of malabsorption. If the patient is having loose motions, then you should investigate for other causes for malabsorption. Again, a very important question that you need to ask yourself is whether the patient was earlier controlled and now has lost his control. Then you should look for the other causes. Rarely there can be an absorption issue, and this I'm sorry, there is no textbook recommendation for that. But when you have tried everything out and you know that this patient is taking the tablet regularly, does not have any malabsorption, you can actually try changing the brand name. Because sometimes a patient for some reason does not respond to one brand and does respond to the other, probably because of the additives that one tablet has. It probably interferes with the absorption. I cannot tell you why, but that is one thing you might want to do. If your patient has got other comorbidities, then you probably should rule out the other causes for this persistent high TSH. As you say that your patient has atrial fibrillation, it is not a very good idea to overtreat your patients, because overtreatment can also actually worsen atrial fibrillation. And so you need to be very careful before you increase the dose. Rule out the other things first. Make sure that the patient is taking it early morning on an empty stomach, not eating or drinking anything for half an hour, and then if required, very slightly increase the dose a little further.
Yeah, thank you. And Shashank, there is a question for you where I believe just click out is Dr. Sonali Bhaumik wants to know about the use of thyroxine. And this is Nishant, David Thomas, and Dr. Sonali Bhaumik. Both have asked the same question technically. Subclinical hypothyroidism in pregnancy. How do you really go and approach for this? Because, and especially Dr. Nishant has a scare that unnecessarily advocating thyroxine in pregnancy can cause some fetal anomalies or fetal malformation?
No. So let me make it three things very clear. That we try to keep the first and second trimester TSH around 2.5 and the third trimester TSH at 3. So if somebody has pre-existing thyroid disease, you need to upgrade the dose. Somebody doesn't have pre-existing thyroid disease and you screen them for a free T3, free T4 TSH, and the free T3, free T4 is normal but TSH is elevated, antibodies are strongly positive, then probably you need to treat. And if there's a history of recurrent fetal wastage, or if there's a history of infertility situation, it's a precious pregnancy, you will probably err on the safer side and treat. By treating, you are not going to do harm. That is number one. Number two, there has been some RCTs which have shown the impact of thyroxine treatment in recurrent infertility and autoimmune infertility. So that data is very much there. But that is only there when the TSH is above 4 or the antibody is positive. Now, this is a gray zone area because these TSHs, which are reference ranges of 2.5, 2.5, and 3, are probably Caucasian reference ranges. And we in India probably have higher TSH set points. So that's an unanswered question. So the Indian Thyroid Society, FOXY, etc., have come out with guidelines. But the current prudent thinking is that try to keep the TSH below 2.5, 2.5, and 3 in the first, second, and third trimester respectively. If in doubt, treat and keep the TSH normal. However, there is no real threat of overtreatment. Having said that, you have a TSH between say 3.5, FT3, FT4 is normal, antibody is negative, it's a normal pregnancy. I may not just treat, I may just serially monitor this patient. And many of these patients, even at a TSH of 4.55, I may just monitor the patient, but it depends on the clinical context. So you need to individualize therapy in these situations. So it's a very good question, but at the same time, you should not undertreat or overtreat. Also remember that many a times we get TSHs of 100, and there also we are told that there should be, you just need to appropriately treat. Treat it just like a non-pregnancy, but in pregnancy, you always play safe and treat. In non-pregnant situations, senior citizens, we often don't treat. In pregnancy, or very conceptual time, we tend to treat sometimes a little more vigorously and target a TSH at 2.5 or 3.
Yeah, thank you. Dr. Ganesh, there is a very tricky question for you. And this comes from Dr. Ashwani Sood. And Dr. Sood says that we have seen some of the patients of Graves' disease post radioablation or radioactive iodine therapy developing hypothyroidism, which are not responding to even supraphysiological doses of thyroid hormone, where we have ruled out malabsorption, non-compliance, and all other things. How do you approach these patients? What should be the thing that you should be looking for?
Yeah. Once again, as Dr. Prasundev was pointing out, so the patients who are not responding to the physiological or supraphysiological thyroxine dosage, we have to reassess the compliance factor first. Most of them will not be taking properly. That will be the first issue. And second thing, after radioiodine ablation, the requirement will be slightly higher only because the total gland will be ablated. So it will be like athyrosis only or total thyroidectomy, post-total thyroidectomy. The requirement will be slightly higher. It will be 1.6 to 2 microgram per kg body weight. So majority of them, if the compliance factor is ruled out, they will respond to thyroxine. Very unlikely that the patients are not at all responding. Then we have to rule out other factors like malabsorption. Probably you have to do the T4 levels after after 2 or 3 hours of giving thyroxine high dosage. Look at the T4 levels. If the T4 levels are not rising after taking 3 or 4 dose tablets or 400 micrograms of 300 to 400 micrograms of thyroxine, then you have to think of malabsorption, something like that.
Yeah. Okay. So we'll need to try and find out. There has to be some factor which is responsible.
Yeah,
usually.
absolutely.
And he has not. Dr. Sood has not specified supraphysiological doses how much he was using. So really you need to be a little more specific while asking the questions. Now, Dr. Prasud, there is a question for you that there is a patient who has got a thyroid nodule and has a coronary artery disease. And you need to investigate this patient. How will you go ahead with it? I know it's a very broad question, but your pointers are very
coronary
simple.
artery disease. the coronary artery disease should not change the way you approach a thyroid nodule. See, the thing that you need to basically look for is number one, whether the patient is hyperthyroid or hypothyroid. If the patient is hyperthyroid, then you'll probably need to do a scan to rule out a solitary toxic nodule. If the patient's blood levels are normal or they are slightly on the lower side, then you need to further investigate this nodule to rule out a malignancy. For that, you will do an ultrasound, and there are some pointers which tells us that this particular ultrasound lesion might be more likely to be malignant. And then, of course, the basically the test of the pudding is doing an FNAC. And if the FNAC has an abnormal report, a Bethesda stage 3 or upwards, then obviously you will need to operate the patient. Depending on how large the nodule is, you can go for a nodulectomy or a hemithyroidectomy, or if you are really, really worried that this is definitely a malignancy, then you can actually do a complete thyroidectomy. But bottom line is that the workup should be thus. If the nodule is hyperthyroid, then you do a scan, and if the scan shows that it is a high uptake nodule, as Dr. Ganesh has already told you, then you can actually give either a radioablative dose, or you can also make the patient euthyroid and then plan for a surgery. If it is a malignant lesion, then of course there is no question, you do a surgery. The problem comes when you have this in between kind of indeterminate kind of an FNAC. Suppose they will report it as a follicular lesion of undetermined significance. Now here also there are some nuclear changes which suggest that this patient might be having a tumor, and it's probably safer to go for the surgical option in these patients also. I do not think the coexistence of coronary artery disease would change this, except for the fact that if it is a solitary toxic nodule, you obviously need to be more aggressive about treating that, because that hyperthyroidism can affect adversely the heart.
Yeah, thank you, Dr. Prasoon. There are 150 questions already. Friends, I may not be able to take all, but quick one-liners from each of these brilliant, faculties. Shashank, TSH levels cutoffs for pregnancy, where you should be treating, you should not be treating.
I already said it. Keep it at 2.5, 2.5, and 3 for second and third trimester. But otherwise you can't have a generalized question that you should treat or not treat. These are the targets for population who are already hypothyroid. And if you are subclinically hypothyroid, you need to reevaluate. With presence and absence of antibodies, presence and absence of infertility, presence and absence of recurrent fetal loss, and whether it is a precious pregnancy or not.
Yeah, thank you very much, Shashank. Now, Prasoon, atrial fibrillation with fast ventricular rate, not getting controlled, hypothyroid patient, will it be wise to combine it with beta blockers, or you would go for some other rate controlling agents like ivaveridine?
Oh yes,
And
two different questions then. You will have to treat these patients' hypothyroidism properly, because we have seen that it worsens the cardiac outcome. And if the patient has tachyarrhythmia, then you treat it accordingly. A beta blocker is always a good option, and you can give a beta blocker, but you need not club the two treatments. If you need to treat the tachyarrhythmia, treat it as a tachyarrhythmia. If the hypothyroidism is not getting treated, you will have to increase the dose, and that's fine. Just don't overcorrect it. That's all.
thank you. Ganesh, Dr. Ganesh, finally to you, is absolute indications for radioactive iodine therapy or the oral, thyroid antithyroid therapy.
Yeah, absolute indications are the patients who are requiring very high dose of antithyroid drugs. Very large goiters usually require high doses, like 30 to 45 milligram of methimazole or carbimazole, not able to reduce the dosage at all. In such scenarios, we have to go for radioiodine ablation. And other scenarios, fluctuating course, like with the 5 milligram of dosage, if you are reducing, suddenly the toxicosis is recurring. When you are increasing the dose of 5 milligram or 10 milligram, the patient is going into hypothyroidism. We do see such kind of patients. Such kind of patients are absolute indications for radioiodine ablation.
Yeah, Shashank, quickly last, there is one genuine request which has come to give us the tips on what not to eat during the thyroid dysfunctions, whether hypo or hyper, foods to be critically and carefully avoided.
So if you ask me very honestly, there is no dietary restriction in general for any thyroid disease. Except for goiters in the past, you can avoid and have regular salt, boiled or mineral water, no cabbage, cauliflower, soya, broccoli, no salty content. But that is very occasional. Very rarely in general grave disease, one can get into an iodine-free diet. The only time we do an iodine-free diet is when there is a thyroid cancer and we want to do a scan. And that is the time we will get you an iodine-free diet.
Shashank, your voice is breaking. Voice is breaking.
So that is when we do, only during the scan time. Otherwise, as I said, there is no dietary restriction for this.
Okay. Prasun, you
Could I
want?
just add
Yeah,
one small
you
thing?
want to add? Yeah.
Yeah. Just that in your routine clinical practice, hypo and hyperthyroidism, no diet restrictions. This is absolutely unqualified. Everyone will ask you this. Tell them that they can eat cabbage and cauliflower and everything. Those things are only not recommended in goiters in very specific situations, as we just discussed, if the patient has already been on a goitrogen or has come from Gorakhpur area, and these patients might respond to not having cabbage and cauliflower. But for the vast majority of Hashimoto's hypothyroidism, there is really no need for the patient to observe any kind of a dietary restriction. The excessive iodine intake should be avoided before a scanning or when you are sending the patient for a radio ablation. But other than that, for routine clinical practice, no diet restrictions.
Thank you very much. Thank you, faculties, friends. Please excuse me and all the faculties not to take all the questions. It is practically not possible. I thank you all for spending all your evenings with us. I would request Professor Dr. Jayant Kumar Panda for the concluding remarks. Jayanto, your acts outstanding. The brilliance of Orissa and the elegance of Jayant Kumar. Over to you. Thank you very much for all your participations and time. Thank you.
Thank you, Mangesh. And that was a very enlightening evening. On behalf of Association of Physicians of India, I extend a very warm thank to all of you for making our program very successful on thyroid disorders. Our president, Dr. Arul Raj, has not only stayed and watched the whole program and given his valuable message, he has formulated the slogan, the digital outreach for knowledge upgradation. And even during this challenging time, he has continued the legacy of API Dash to reach all of you. Thank you, sir, for your inspiration. Thank you, sir, for taking the flag ahead. And Dr. K. Srinath Reddy, who was our chief guest, has spent his valuable evening with us, and he has told not only the global scenario but inspired all of us for the public health importance, and you know how important the thyroid disorder are, which affects almost 1/4 to 1/3 of the population of India. And his presence has not only inspired all of us, has enriched the science in terms of information and knowledge. Thank you, Professor Dr. K. Srinath Reddy. And Professor Shashank Joshi is always an inspiration. He is a think tank, and his participation, his interaction, his dealing with the questions and the topic not only is making us wiser, is making everyone updated for last more than 2.5, 3 decades in India and the world. And thank you for your valuable time. I know you're very preoccupied, but you have spent the evening with us. You have given the message and taken up the questions. Besides, Mangesh is part of the family, and he has made API vibrant, and such a dynamic secretary. API always dreams, and he has given his best to API, best to the CMEs, and to all of us. Thank you, Mangesh, for your intervention, for your presence, for your leading from the front. And I thank the ABOT, especially the managing director Anil Joseph for his presence, and also assuring the support for the unrestricted grant for API Dash program. And besides our speakers, Dr. Prashun Dev and Dr. Ganesh have done a very good job by not only presenting but our physicians need in the country and abroad, but taking all the questions very effectively. And I'm sure there must have many more questions which has come not only from India but Southeast Asia and globally. Many people are attending, as Dr. Mangesh has told you, more than 5,000 doctors are online, and this is a continuing webinar education, continuing online education, continuing virtual education for all of us. So your presence, Dr. Shashank, Dr. Prashun, and Dr. Ganesh, has made the scientific content very rich and very understandable for all of us. And at the end, I thank API for such a beautiful opportunity for all of us. And let it continue. Let the API Dash go on enriching your knowledge and understanding. And besides, I thank Jyotishman Barua and the whole team of ABOT, Miss Swati and whole team for the technical support they have extended this evening. And the ABOT team have taken a beautiful job of hosting this API DIAS program continuously for last 10 years during the tenure of different API team, and continuing during this difficult time. So I thank the whole team of ABOT, and especially the managing director who was present today, and Jyotishman Barua, who is instrumental from the day one. I know way back in 2013 we interacted to start the programs, and with this, every good thing must come to an end. And with all your presence, all your participation, I thank all the participants, the national and the overseas, for your participation, for asking questions, for listening to us, and making the program very successful. And I'm sure this will go on. API will continue this legacy of spreading knowledge. And finally, before I end, I request the team about, especially Jyotishman, to give a concluding remark and end the program.
Jayanto, before Jyotish comes into, I have a small announcement for all the listeners and all the participants that tomorrow there is a program again at the prime time on the gastrointestinal disorders, and also on Sunday at the same time we have got a program on sleep disorders. And I also like to express on the behalf of Association of Physicians of India our gratitudes and heartfelt thanks to today's MMC observer, Dr. Agam Vora. Thanks for being there, sir. Friends, to join this program, this is a Maharashtra Medical Association accredited program. For attending this program, each participant will get 1 credit hour for attending the whole session. So please do attend in large numbers and take the advantage of this aim of Association of Physicians of India and Professor Dr. Arul Raj, where we are trying to reach the unreachable through the digital extent. Over to you, Jyotish, for the corporate thanks.
Thank you so much, Dr. Tiwaskar and Professor Dr. Panda. It is always indeed a great pleasure always to come to the platform and listen to all the dignitaries. A special thanks to Professor Arul Raj, the President of Associations of Physicians of India, Dr. Tiwaskar, the Secretary General of Associations of Physicians of India, Professor Shashank Joshi, the Dean of Associations of Physicians of India. Also today's speaker on thyroid disorders, Professor Srinath Reddy, who is the president of the Public Health Foundation of India, for his gracious presence as a chief guest for today's program. The speakers for today are Dr. Prasoon Dev and Dr. S.K. Ganesh for such a valuable session. All the delegates are present. And most importantly, there also Dr. Agam Vora, who is the observer from the Maharashtra Medical Council today. With this, I also thank my colleagues, Mr. Anil Joseph, who is the managing director of Abbott India Limited. My colleagues from the marketing team and the commercial teams, Neeraj, from who is basically the business head for the metabolics, Preeti, who is the marketing and the head for metabolics team, the team from medical, including Dr. Gyotana, and Dr. Pavanandan, who is recently joining the team. So I also thank the back-end teams headed by Swati for nice coordination about the entire logistics for the event. Again, indeed, special thanks to Dr. Tivaskar for his brotherly advice always, as always, and Dr. Joshi, as always, whenever I learned from him, and as my elder brother. Thank you so much. Kindly join us for tomorrow. The sessions on gastroenterology, as well as the session on sleep disorders day after tomorrow. Thank you so much. We wish your support and collaboration like this to take this dissemination of information to API speakers to the next level. Thank you so much.
Good night. Good night, everyone.
Good night, everybody.
Good night.
Bye bye.
Good night.
Stay safe. Bye bye.